Να συνεχίσουμε, γιατί είμαστε και λίγο πίσω στο χρόνο.
Let us proceed with the next speaker, Mrs. Ntourntoufi Agathi, a pediatrician and an IBCLC, who will enlighten us on the issues, on the factors preventing a neonate from breastfeeding. She is also a neonatal specialist. Those of us who deal with this specific field sometimes are called upon to try to prove certain things that are self-evident in a way. Anyway, sometimes people say stop breastfeeding without thinking about it too much. In the past, this was the approach. There were many doctors in the past who would give a therapy for women who ended breastfeeding, who stopped rather breastfeeding. But anyway, currently the trend is being reversed, and more neonates have the possibility and the opportunity to breastfeed. Good afternoon, ladies and gentlemen. I'd like to thank the organizing committee of Galaxias as well as the local committee, Mr. Varakis and Mrs. Bazula. I'd like to thank them for the invitation to participate in your conference. The medical reasons why a neonate can't breastfeed, that's the theme of my speech. Maternal breastfeeding is the natural and ideal way of feeding every infant. Can it be achieved under any circumstances? Well, most of times, yes. There are problems and there are some side effects. Not side effects, there may be some problems on behalf of the mother, but there may be some problems on the part of the baby. However, the medical reasons why breastfeeding is contraindicated are very few, and they have to do, many more are the difficulties that we encounter when breastfeeding children with special problems. Metabolic syndromes of the neonates are a contraindication. We usually see difficulties in premature infants, in infants with jaundice, in infants with muscular tone disorders or chromosomal disorders, and in neonates with dehydration or tongue tie or other issues. Metabolic issues are of paramount importance. Unfortunately, they translate galactose into lactose. This is quite a frequent phenomenon. Galactosemia requires a nutrition free of lactose, milk with low content of lactose, and no breastfeeding. The illness is rather all neonates are controlled for this specific problem. PKU is also frequent. It requires the administration of milk which does not contain phenylalanine, but there are cases where we can have partial breastfeeding, so that the neonate can get the benefits he or she can get through breast milk. And the diagnosis for that is quite easy. Now, we may have some issues during the application of the method of breastfeeding, but there are solutions for that. The preconditions for a successful breastfeeding process are the following. We need to have a healthy, neurologically mature infant, an infant with a cardiovascular function that is proper, with an anatomical development that is good, for it to be able to coordinate what is necessary for breastfeeding, because it will need to synchronize the actual act or gesture of breastfeeding with swallowing the milk, and it may be the infant needs to be able to breastfeed in a few words. Premature babies below 37 weeks of gestation, and which amount to 10% of births, usually have issues. 3/4 out of this percentage do face problems. We have premature neonates, but these neonates benefit from breastfeeding, but unfortunately breastfeeding percentages are very low for this category of neonates, of babies. Reasons for the failure of breastfeeding are the following. The babies are distanced from their mother quite early, then they are owed to some functional and anatomical problems, to some side effects because of the fact that they are premature. And very often the above factors render the onset of breastfeeding quite difficult, and they actually delay the onset of breastfeeding. And the psychological factors affecting the mother are indeed an important problem for breastfeeding, the breastfeeding of those babies. Therefore, tailor-made approach is of the essence. A tailor-made approach not only of the mother and the baby, but also of the whole family. So, over the past years, many countries have been adopting a family-centered approach and therapy of such neonates, laying emphasis on the participation of the parents in providing care in the hospital. Dealing with such cases require an appropriate training of the personnel of the hospital or of the care unit. So, UNICEF and the World Health Organization has enriched the baby-friendly hospitals and has extended such characteristics to neonatal hospitals. The personnel needs to be well-trained to provide advice, to be able to discuss with the mother and to try to realize, to understand whether the mother wishes to breastfeed or not, whether the mother is aware of the benefits of breastfeeding, to provide the necessary instructions for the mother to be able to actually get the hair milk and maintain it, preserve it well, how to do it, how to store it, where to store it, instructions and guidance pertaining to the skin-to-skin contact when possible, and if possible, but of course the more the better. And the mother has of course to be aware of the fact that breastfeeding with premature babies require time, so the mother needs to be patient. The method of feeding of premature babies Mr. Liosis provided information on that. So we start feeding them quite early after birth, when their cardiovascular function is stable, even if they are very, very tiny or very premature, through what we call nutrition feeding or minimal feeding, mainly through the breast milk. So this is how we start with such device. And with babies above 32 weeks, by feeding the baby through this device, the parent needs to place the finger in the mouth of the baby, so in order to verify that the baby is in the position to proceed to the necessary muscular movements to drink the milk. Then another way is this way of feeding through a kind of glass, which is not exactly a glass, and feeding the dry feeding now happens rather when placing the neonate on the breast without the baby necessarily drinking it, either because the baby is not in the position to do it or because the mother doesn't have milk. But it is important to do so because we help the baby familiarize with the mother. Skin-to-skin contact is thus promoted. The mother becomes familiar with her premature baby, and then transition to a more complete breastfeeding will be smoother. Out of most premature babies, late preterms, 34 to 36 plus weeks. Well, this is a category of babies which need special attention. They would be considered mature, but they are not mature, not neurologically mature. Their muscular tone is quite low, is not strong enough, and this can lead to a reduced intake of milk, and it can also lead to a decreased reduction of milk production. So these babies at times manifest problems of weight or dehydration, or they need to be taken to the hospital at times. So they are more prone to, rather the breastfeeding process is more prone to fail, unfortunately. So they need special care, special monitoring in order to guarantee that the breastfeeding process taking place is efficient, and that the quantity of milk that they take is sufficient. They need to be monitored closely when in the hospital, and then they need to be followed up, monitored when they go home, in order to verify, in order to guarantee that the breastfeeding is well established. So this is all I had to say about premature babies. Jaundice is another frequent issue, a very frequent issue for neonates. And this often leads us to wrong choices, and we stop breastfeeding, unfortunately. What is jaundice? It is this yellowish color on the skin because of low bilirubin in neonates, and this is a problem that appears in the very first days of the life of the neonates. And we see that very often with premature babies. Bilirubin, as Mr. Newmus previously said, is something that, if in normal levels, does not cause any damage. On the contrary, it functions as an antioxidant for our body. However, high levels of bilirubin may lead to a disorder of the central nervous system, and this is an issue of major concern. And this is also an issue causing problems when dealing with neonates, and especially breastfeeding ones, because they are the ones that more frequently manifest higher levels of bilirubin. This is a graph that shows on the low curve we see the neonates who do not breastfeed. We see that there is a peak, but take infant formula, we see a peak of bilirubin and then we see it disappear. But breastfeeding neonates, we see that the peak, this peak that they manifest on the 5th day, it may go on and it may go on and remain increased, remain quite high, even for 2 or 3 weeks, and for many of them, even also during the 2nd and the 3rd month of their lives. So why do breastfeeding babies manifest jaundice? There are 2 categories of jaundice. The one caused by breast milk and the one by breastfeeding. The one due to breastfeeding appears in the first days of life because the intake of milk is not sufficient, whereas the other kind of jaundice is due to levels of bilirubin and the jaundice in this category of neonates is usually accompanied by a loss of weight up to and more than 12%. They don't urinate enough and they do not
γίνεται μετά τη 14η μέρα ζωής. Δεν έχει διευκρινιστεί σε
despite the many studies that have been conducted, we can't yet be sure, but it is allegedly rather some substances of the breast milk lead to the re-intake of bilirubin in the colon. And this kind of jaundice remains rather up to the 3rd month, and it may affect from 20 to 30% of babies who breastfeed. Bilirubin is always of an indirect type. And in order to come to the conclusion that the jaundice is owed to breast milk, then we must exclude or other factors or reasons. And we need to pay attention to the color of the discharge of the baby. So, the appropriate monitoring of the baby is of overriding importance for doctors to be able to spot the reasons for reduced feeding, and in order to provide the necessary instructions and advice to the mothers in order to avoid future problems and in order to successfully deal with the levels of bilirubin. So, a baby with jaundice who breastfeeds needs to breastfeed in the appropriate way. We may need to apply phototherapy, for example, and there are some curves of the American Society of Pediatricians which have been adopted by the Greek one. So if we need to apply phototherapy, then we should do it. Then we do it. But breastfeeding needs to continue. When the baby needs a transfusion, then we may need to interrupt breastfeeding for some time, but the mother will still need to pump the milk in order to administer it, to give it to the baby through an alternative way later. We never give water or water with sugar or modified milk in order to combat the problem of bilirubin. We may give pumped breast milk in case we have a neonate who is dehydrated or who at the same time may follow a parallel therapy. Particular attention is required for quite big premature babies, especially the jaundiced ones. We need to constantly assess and follow, rather we need to follow up such babies when at home, when a neonate leaves the hospital with jaundice, and especially the ones breastfeeding, they need to be reassessed within 24 hours. We need to be able to assess the clinical state of the infant and take the appropriate measures in case this is necessary, of course. We do not interrupt as in the past, as a few decades ago. We do not interrupt in order to have the diagnosis of jaundice because of breast milk. Interruption of breastfeeding was recommended in the past. But this is not the case anymore, because this method may lead to an interruption, to a cessation rather, of breastfeeding as a whole, and it also may lead to it may conceal other causes of jaundice. So this is not the method to follow anymore. Another metabolic disorder, quite frequent for neonates,
is hypoglycemia. And of course this has to do with neonatals who are breastfed, and especially those who are not well breastfed, is hypoglycemia. But still, there is a category of neonates that we should absolutely control and check glucose in the blood, especially in natural newborns. There's no need to be able to calculate blood sugar levels and the glucose of the blood, in other words. And of course, we know that children with minor hypoglycemia and neonates, after the weaning and especially after the birth, contributes to a non-existence and non-creation of problems of hypoglycemia to the neonate. In other words, we should avoid calculate blood sugar levels in natural-born babies who are fully breastfed, especially during the first days after their birth. And of course, we only need when these newborns have symptoms of hypoglycemia and have a tremor and certain irritation or other symptoms. And of course, we need to see the premature babies, less than 35 weeks, those who have a low weight for the life, the overweight children, more than 4 kilos, or more than other factors. Now, children who are sick, who have hypothermia, newborns from diabetic mothers. There are special protocols to address this issue. And we need, of course, to continue to breastfeed if, of course, the status of the baby helps us to do so. Another very constant problem that we believe have all heard about and has to do with the percentage of rather 10% of newborns is the problems with the tongue that we all know. We do know that it has this tongue dict, this special phenomenon as far as its position, as far as its size, the lack of elasticity, which disrupt the mobility of tongue. And this, of course, creates problems of its size. And as we heard earlier, this could be an important consequence for difficulty in breastfeeding and even the disruptive breastfeeding. The diagnosis is quite difficult sometimes due to the issues related to some other criteria, because whenever we see that the tongue dict is visible and there's a problem of diagnosis, things are more difficult, but still sometimes we are quite perplexed and challenged because we have difficulty in identifying the problem, that the problems of breastfeeding is related to the tongue dict. There are different types of tongue dicts against the severity of the problem, but tongue dict might have important consequences in the process, as we heard earlier, of breastfeeding, because more than 50% of newborns who are breastfed and have a short tongue dict will have difficulty in breastfeeding. But of course, this will also create additional problems to the premature stop of breastfeeding. So we need, as soon as possible, to be able to detect a case of a tongue dict. Now, what is the diagnosis of tongue dict? Well, there are some symptoms that are calculated from mother and from newborns. Now, the symptoms for the newborn are the following. We see a neonate, which is rather anxious, is irritated, has difficulty in attaching him or herself to the breast itself. Its lunches are longer than usual. The quantity of milk that the newborn receives is limited, which of course can create a low increase of weight. On behalf of mothers, it is a mother who is in pain and might suffer a lot. Her nipples are traumatized. We see problems of its nipples around the end of the lunch. So all of these things lead to additional problems and, of course, to a low production of milk, and thus we enter in a vicious circle from which we cannot escape. So we see that we might have problems additional that we should seriously take under consideration. Now, whenever we have problems in tongue dict, the severity that it can be addressed and assessed by utilizing the operationality of the tongue in a scale, as the Hasselbalch assessment tool for lingual frame of function, or some other evaluation methods that I will not get into details. Now, the Hasselbalch system, the assessment tool for lingual frenulum function, tries to assess the criteria of utilization of tongue and how tongue is presented within the mouth, and what are the criteria as far as its functionality and its operation itself. These are calculated in the Hasselbalch assessment tool. I will not get into additional details, but we can arrive at the conclusion whether this newborn needs a section of the tongue dict or not. Now, through various studies, we have calculated and seen that this system, the assessment tool, the Hasselbalch assessment tool, is quite important and, of course, has a good status. Now, Well, we see a mother and a baby have some symptoms, then we should continue with a systematic assessment through a specialist in neonatal consultant who has the appropriate knowledge on such issues. Now, in order to help and support women and newborns should be personalized, because sometimes we see that the constant exposure to symptoms creates an additional stress to mothers and, of course, to infants, and this can lead to an abnormal stop of the lactation. Now, as far as this section is concerned, should be considered as an efficient method in newborns who have difficulty in breastfeeding, especially in neonates who didn't have a greater result after a short period of time, in other words, after 2 or 3 weeks, through the help of a specialist. So it seems that section of tongue dict is safe and secure when it's been done by a specialist. Many studies have shown the benefits of the section of tongue dict. We have seen that 80% of neonates who needed section of tongue dict are fed much better after 24 hours. So symptoms are much better for women 48 hours after the section to the tongues, to the infant's tongue. Now, I want to make a reference to tongue dict because it is a quite problematic situation, which sometimes we need to think whether we should refer the newborn to another doctor. So when we see an infant who has some problems, sometimes we tend to say that we need a specialist for a section. Well, this is not always the case. We should not move forwards and proceed a section directly of the tongue dict. And we should always make a separation and see each case differently. So, is it a case related to the tongue dict or to another situation, to another problem? So this is something we should look upon and try to assess. Because difficulties are not always related to tongue dict, even to children who suffer from tongue dict. They might have other problems related to breastfeeding. And of course, according to a series of studies, it seems that treatment via section should be conducted whenever tongue dict creates problem to breastfeeding. If we have a child and a mother who managed to have a good relationship in terms of breastfeeding, even to avoid future problems of speech, well, once again, I'm saying tongue dict and the section of tongue dict is not something we should move forward to. Now, moving forward, I should also talk about the cleft palate. It is 1 out of 600 babies who might suffer from cleft palate. It is something that we have seen quite rarely. We're dealing with newborns with various combinations of cleft palates. As you can see over here, we have a newborn with a cleft palate. We see the first baby who has a minor section on the upper lip. The second has full cleft palate on the upper lip. And the third one has cleft palate on both sides. So we see pictures of children with cleft palate. If they receive a really attentive help, in most of the cases we will have difficulties in being breastfed, whereas newborns with cleft palate cannot be breastfed, in most of the cases cannot have milk, because they cannot create this negative pressure during the lactation process. Well, I will not insist on all these things. We offer guidelines to mothers, especially the ones with cleft palate, to place their offsprings in such a manner for the children to close this part. If, for example, a child has a right cleft palate, we suggest to the mother to place the child in a cross-canal right position, in order, through the pressure on the breast itself, to close the cleft palate. Moreover, it is suggested the dancer's position. So she places her hand underneath her breast, or the rugby position, or the with open legs, let's say. Whenever a mother cannot help her baby and the baby suffers from cleft palate, having tried all of these solutions and the baby still cannot be breastfed, we then suggest to pump the milk and administer the milk through an alternative way. I will not insist with babies with hypotonia or hypertonia. Now, we're dealing with very stressed babies who cannot grab the breast. So whenever it's hypotonia, they cannot actually attach themselves to the breast efficiently, and they cannot suck milk from the mothers. Once again, we offer guidelines as far as those babies are concerned. Skin to skin, pump of milk, and administration of the milk, of course, through an alternative way. So hypertonic babies we should try to place them in a relaxed atmosphere, in a very relaxed room, in a comfortable way, where we should try to do some massage on the baby for the baby to be relaxed and be able to continue trying to grab the breast. So the cradle hold is really, really helpful. And in hypertonic newborns, we can use the marsupials or the dancer's position. That will equally help the baby to be better positioned against the mother's breast. So as a conclusion, I'd like to say that neonates who will not receive breast milk or any other milk, leaving aside the infant formulas, is very rare, and we're dealing with newborns with metabolic syndromes. We're dealing also with newborns who have a better nutrition, and sometimes we have to administer some other formulas. Premature newborns and newborns with hypoglycemia, newborns with special needs, and in this case we cannot breastfeed directly from the mother's breast. Milk can be administered in alternative manners, as I said earlier. many pathological situations of the neonate might affect the success of breastfeeding, it is important to early diagnose and, of course, face a problem and find solutions. And last but not least, we need to identify and find advice as early as possible by specialists in lactation. So we need to address the problem as soon as possible, and the results will be much better. Thank you very much.
Θα ήθελα να συγχαρώ την κυρία Ntourntoufi.
I'd like to congratulate Mrs. Ntourntoufi on her well-documented presentation. We are running out of time, so if you have brief questions, that would be okay. Mrs. Grafakou, thank you very much. Well, mine is a very brief comment on breastfeeding and metabolic issues. A contraindication is galactosemia, and the common galactosemia. There are some cases when we shouldn't maybe stop breastfeeding, but we always interrupt it, we always end it. Feeding is a mix of regular milk and special milk. This Venizeleio is another case where mixed feeding is a solution. And with reference to the other metabolic syndromes, the child may not be in the position to breastfeed, but it may receive pumped milk, breast milk that is, in order to get the benefits of breast milk in general. Breast milk contains 6 times less phenylalanine if compared to modified milks, to ready milks. But in that case, I believe that very close monitoring should be the case. Let us move on. Thank you very much.